All right, good morning, and we had a discussion a little bit about anesthesia and what kind of anesthesia. And a lot of people have concerns about anesthesia. And I think we talked yesterday about a couple patients and their experiences with anesthesia. We had the woman who sat over here who actually required a whole bunch of anesthesia, and that her husband had actually had a terrible experience where he woke up during his surgery. And that was not a surgery with us, but he had a bone surgery and woke up. So people want to know about anesthesia, want to talk about it. But I'd like to point out, remember yesterday's clinic, all the patients that were there who'd had surgery with me, did anybody have a bad experience with anesthesia? Right? Right? And your anesthesia experience is, you don't remember anything? Is that the deal? Or?
Yeah, I think it took me a long time to wake up, but I think I've had that situation before, so I think I'm just...
Well, we intentionally use drugs that last longer. Okay, so the long time wake up is not a criticism. It's designed to make your system a little bit sleepy so you sense the pain and discomfort that might exist after major surgery less. Just to turn that down a bit, if you understand that. Right. So we do have a lot of times our guys will say, you know, I can't wake up. And you're going, well, maybe you should sleep. So we have types of anesthetics that work very quickly and go away completely very rapidly. And in fact, I used to use that. But then you're awake and kind of uncomfortable. Why not be a little bit sleepy and take a longer time to wake up and let the discomfort of the surgery melt away? Remember that if you stub your toe, right when you hit your toe, there's an intense flood of the sensations of pain. And then most injuries have that peak and then it begins to go down. So why not be a little bit sleepy for the first couple of hours? You don't need to be awake. We don't need you to do anything. We don't need your help right now. Thank you. You know, rest. Go to sleep. The other thing that I thought was an interesting story yesterday, we had a patient who said that her experience with us was a very good one, and that she had had a past experience with anesthesia that wasn't very good, and that she had told doctors in the past that she needed higher doses of pain medicine and things like that. And then we found the funny story about her being in Louisiana in a drinking contest where she could really drink a lot of alcohol, and compared to, I didn't get all the details of it, but she has the ability to metabolize chemicals, and that's through some enzymes in your liver, and she must have a lot of those enzymes. So she had anesthesia with us and did very well, I think she told us, and that experience was related to the fact of the kind of anesthesia we do. So we put on your forehead the equivalent of an electrocardiogram, an electroencephalogram. We measure your brain waves. So we don't just give you a drug dose and guess if that's okay. Instead, we give you a drug dose and see what your brain has to say. And what the idea is that when you're wide awake, you have a very rapid, high, spiking electroencephalogram. And that when you fall asleep, those spikes go down and they're flatter and smoother. And of course, you know, if you have a completely flat one, that's where they worry about whether the brain is working at all. So in that patient, we measured her electroencephalogram, and we watch it, and then we give more medicine until we can see that the level turns down. And we found, just like the sailor she was competing with in the drinking contest, that it took a lot more medicine to decrease her EEG. She took about 3 times the dose of most of our patients. And that's okay, and she did great. We knew to give her a lot because we were measuring this. When you just give anesthesia without measuring that, my opinion is that you have less ability to titrate the dose to just what each person needs. Now, in this area of the United States, we have a lot of church members of the Church of Latter-day Saints. And they don't drink, and so we often get young women in who are Mormons, and we find if you give them just a little bit of anesthesia, boom, they fall asleep. So they need much less anesthesia than our drinking patient from yesterday in clinic. Because if you can actually adjust those enzymes. If you've ever seen an alcoholic, they can drink lots of alcohol and it hardly bothers them. And then you have, a teetotaler who drinks one sip and boom, they're out. Well, those different people are different in each one of us as we sit here this morning, and each one of us uses our liver enzymes to metabolize anesthesia drugs and alcohol better or worse than each other. We have different capabilities, just like we're different height and different weight and different gender and different hair color. That ability to metabolize anesthesia varies, so it's nice, we think, to have this monitor to watch and see how much medicine you need for anesthesia. Now, there are two other important points I think about our anesthesia where we're using some really advanced techniques. The foundation of most other doctors' anesthesia is a gas anesthetic and narcotics for pain. Okay? Gas anesthetics are from the origin of anesthesia. Anesthesia originated in what's now called the ether dome when a dentist gave somebody the gas of ether to breathe. He went to sleep and then he took out his infected tooth. And for years, we have been using, and we still use today, variations on gas anesthetics. And they're great. They're good choices. Most everybody in the country this morning who's going to have anesthesia will get gas anesthesia plus a narcotic for their treatment, and we don't do that. The gas anesthetics are great, they're cheap, they're effective, but they have two problems. One person out of 3 who gets them will wake up with severe nausea and vomiting. Just terrible retching. That's bad. It's not deadly, but the patients who've had it, no fun. The other complication is because it's a fatty, greasy, lipid-soluble chemical, the gas will dissolve in the fatty tissue of patients. And sometimes enough gas will go into the fat so that when you wake up, you will clear the anesthesia from your blood. They'll take you to a recovery room, you'll look like you're wide awake, but there can be a store left behind of gas in the fat. And enough of that sometimes can sneak back in where it can drop your breathing and cause a complication up to including low oxygen and even death. And that's rare, but in heavy patients, you don't want anything that depresses respiration because a heavy person already comes with some limitations on the lung function because of their weight. Many of our patients also have sleep apnea and snoring and things like that. So the gas effect, even if it's small, is going in the wrong direction. It decreases and interferes with breathing, and we don't want anything that does that. So we're not going to use gas anesthetics. We're going to use an intravenous anesthetic technique which does not cause nausea and does not build up and does not come back, which the gas anesthetics may. The second thing that's really common, and you probably know about this, is most pain medicine can be classed in 2 types. One is all the stuff that you can buy in the grocery store. Aspirin, Aleve, Motrin, Tylenol, stuff like that. And all that's very weak. And then strong pain medicine, almost all strong pain medicines are narcotics like morphine and Demerol and codeine and drugs like that. And so almost all surgical patients get narcotics post-op as a treatment for their pain. And again, narcotics are great and it's a good choice and doctors are making a good choice with it. But again, the narcotics have 2 problems. And the problems should sound familiar. One is nausea and vomiting. If you've ever taken codeine or something like that, it makes you sick on your stomach. So a lot of times people get pain medicine and they throw up and get nauseated. If they've had gas anesthetic on top of that, the combination can really leave you feeling terrible and retching and vomiting. And we don't want that after our surgery. The second complication is that narcotics depress your breathing, just like the potential risk of the gas anesthetics. And a narcotic dose in a heavy person, all of a sudden you've got a potentially deadly situation if you drop a heavy person's respirations with narcotics. That's how narcotic addicts can kill themselves when they have an overdose. They just stop breathing. Okay? So we want our patients to have pain relief, but we don't want them to have too much narcotics where it affects their breathing. And so we use a whole new area of research called opioid-sparing analgesia and anesthesia. And that goes back to something that's kind of subtle and complicated to explain, but basically it works like this. If we can find a drug called a narcotic that can go to a place in our brain and take away pain, are there any other places in the brain that we could affect that would help with pain? And the answer is yes. We have found other places in the brain other than the narcotic receptor that we can stimulate to block pain. So we use two other receptors. One is called the NMDA receptor, the N-methyl D-aspartate receptor, and the other is called the alpha-2 receptors in the brain. And so we add in drugs that affect those areas so we get pain relief without the side effects of the narcotics. So when you put that combination together, you get a much safer anesthesia, a more supported breathing system. Instead of depressing your breathing, we stimulate your breathing, and you get good pain relief. You notice all the people in clinic, we heard very little about anybody having pain. And I think you said yesterday you had surgery and had very little pain.
I had no pain.
And 11 years ago, do you remember, did you have pain?
I had a little bit of pain.
Okay. And how long were you in the hospital?
Just one night. I believe it was just one night.
One night? We threw you out early?
It may have been two, but I think
11 years, it might have been two.
it may have been two.
Yeah, 11 years ago, it might have been two. I remember the day when everybody thought 11 years ago it was very radical to send people home after major surgery in 2 days. And so I had a woman who was a nurse from Michigan, and the day after her surgery, she called and said, I want to go home and everything. I said, but you're a head nurse and an operating room, you know how dangerous this is. And no, I'm fine, I want to go home. And anyways, I fought with her on the phone, I'm your doctor, and well, I'm a nurse, and so like you, I said, yes, dear, and let her go home. And she went to the hotel, did fine. So next week in clinic, I said, oh, this lady was so rough on me, she had to go home in 1 day. And so all the people went, you mean we can go home in 1 day? We don't have to stay 2 days? I went, okay. So then we started doing it 1 day, and most people do pretty well with that. So the anesthesia that we use, you can look at the people we have here, we can look at the people you've talked to, the people who were in clinic yesterday, very little pain. We intentionally use drugs that make you a little sleepy for a little longer, but it stimulates your breathing, less narcotics, and no gas anesthesia. So it's very safe, it's very comfortable, and in general we have really good results with it. So we're very proud of using kind of these newer, safer anesthetic techniques. Most other doctors that I'm aware of are not using these yet. We're very excited, and we studied them recently. We switched by adding this opioid-sparing analgesia technique, and we counted the number of narcotic doses people needed. We said, if this is supposed to be good, let's see in the recovery room how many times our patients raise their hand and say, hit me with some more pain medicine because I'm uncomfortable. And what we found is we decreased the need for narcotic pain medicine in the recovery room by 90%. So we were doing pretty good in the past, 11 years ago. We're doing even better over the past year with this new technique. So we think you'll be real happy with it. It's very safe, and it's something we're very proud of. It's one of the other things that we do and pay attention to. We like the fact that we think kind of every step in our process is an area that we focus on to try and make better, try and make it the best we can for you. The pre-op process, the educational process, maybe using the iPads, using the internet, having videos on iTunes, on the YouTube, anesthesia, the surgery, the surgical instruments, everything is something we constantly focus on. And that's the advantage of just doing one surgery. It's all I think about day and night, every day. And there is some research to show that you get better results when you do a lot of something. And as you get higher numbers and more experience, you tend to get more skilled at that one area. And we respect the doctors who do so many things, but for this one surgical technique, I get up in the morning, I go to sleep at night, every day I'm thinking about this surgery. And anesthesia is one of the things we think we've done a really good job on, and we hear back from our patients they really like it, and it's very safe. So